I have the good fortune of working with a number of basic clinical and population scientists across a number of institutions, including Mass General, the Broad Institute, collaborations with the Framingham Heart Study. Our work is really focused on understanding the mechanisms of atrial fibrillation through human genetics, understanding how best to identify patients at risk for atrial fibrillation and atrial fibrillation morbidity using a number of different techniques, including mining the electronic health record, and improving outcomes in patients who have atrial fibrillation or who we identify with atrial fibrillation through these new mobile health technology platforms. What we know about atrial fibrillation is that it's a common and morbid arrhythmia associated with substantial economic burden. We now appreciate that the probability of developing atrial fibrillation, if one makes it to the age of 55, is about 37% over the course of their lifetime. Genetic predisposition and clinical risk factor burden are important variables that explain the variability in atrial fibrillation risk. Individuals who have the highest burden of genetic predisposition or clinical risk factor burden have approximately a 50% chance of developing AFib over the course of their lifetime, whereas those who have the lowest genetic or clinical risk factor burden have only a 20% probability of developing AFib over the course of their lifetime. And in addition, what we've seen is that a healthier lifestyle is associated with a delay in the onset of atrial fibrillation by about 7 years among those who have the healthiest risk factor profile. I think what we now appreciate is that genetic risk factor burden plays a substantial role in risk of developing atrial fibrillation. And I think as we start to learn more about the genetic basis of atrial fibrillation, we'll be able to use that information in a number of ways. One of which is we'll be able to better assess risk of individuals for developing atrial fibrillation. We'll also have a better understanding of the biology of atrial fibrillation and hopefully be able to identify new therapeutic targets for atrial fibrillation, a disease for which we have very limited antiarrhythmic therapies right now. In addition, with the emergence of mobile technology, we're starting to appreciate the overwhelming burden of atrial fibrillation in the community. There are a lot of questions we don't have answers to right now about the burden of atrial fibrillation and how it relates to stroke or other morbidity, and how we should best identify those patients and treat those patients when we do identify atrial fibrillation.